Hello nurses, welcome to another session of Nurse Talk. In today's session, we are going to discuss inflammatory cardiac conditions. Mainly, we are going to see what endocarditis and rheumatic heart disease are. Okay, so the first one is endocarditis. Endocarditis or infective endocarditis is a disease condition resulting from the microbial infection of the endothelial line of the intracardiac structure. So we all know the heart has three layers: epicardium, myocardium and endocardium. Endocardium is the innermost layer of the heart which actually covers the valves and the inner portions. So if there is any microbial infection causing destruction or injuries to the endocardium or endocardial layer will result in endocarditis. Itis means inflammation. Endocarditis means inflammation of the endocardium. Okay, so what is the risk factors? What are the risk factors of endocarditis or infectious endocardium? So these risk factors are, first one may be structural heart disease. If there is any issues in the structure of the heart, that can be resulting. Otherwise, rheumatic heart disease can also be a risk factor of endocarditis. Sometimes prosthetic valves for the patient, that means the artificial valves or cardiac devices like pacemaker can result in endocarditis because any inflammation happening to the valves, that is artificial valves or the pacemakers of the artificial pacemakers, can result in endocarditis. Otherwise, injection drug users they usually use those who use syringes. So spread of infection through the bloods can also result in the endocarditis. Otherwise, chronic IV access. Okay, so when we are saying about the chronic IV access, what is the maximum time which we can keep an IV line for a patient in our ward or the medical setup? Remember, the maximum duration of an IV line to keep on a patient's artery or vein is 24 to 48 to 72 hours. So any IV line which is on a patient for more than 72 hours should be removed, or 3 days. We cannot keep an IV line for a patient for more than 3 days because of the chances of infection. So this can also be a question for how long can we keep an IV line for a patient. So it is 3 days or either 72 hours. So we need to remember that thing. So chronic IV access can also be a risk factor for the patient who can get endocarditis. Okay. So next, we are going to see how is this infection, what are the causative organisms and how is this infection going to get to the cardiac structure of the patient. So what are the bacteria, what are the reasons or what are the causative organisms for endocarditis? It can be bacterial, or other than bacteria like fungi or brucella, etc. So among the bacterial organisms which result in endocarditis, that can be streptococci or staphylococci or enterococci. So these are the bacterial groups which can result in the occurrence of bacterial endocarditis. Then we are going to see what is the pathophysiology. How is the patient is going to get affected with these microorganisms or bacteria, and how is this transferring into the endocardial layer of the heart. So the pathophysiology, either the patient can get the infection through oral cavity. That means if the patient has got an invasive dental procedure in the last 3 to 4 months, the patient is at risk of having endocarditis, because in case if the patient got any bacterial invasion through the dental procedures, that can result in the endocarditis. The second thing can be infection. Example, genitourinary infection. If the patient has got the genitourinary infection and it got spread into the blood, and then it can reach the endocardium of the patient. And the third reason can be surgical procedures. Surgical procedures means any invasive procedures like application of prosthetic valve or application of an artificial pacemaker, or otherwise the same thing is IV IV cannulation for a prolonged period, which is not removed for more than 72 hours, and the patient is keeping the same IV cannula for more than 72 hours or 3 days, that can also result in the endocarditis of the patient. So what all things did we discuss now? Endocarditis means the inflammation of the endocardial layer of the heart, which can be affecting on either the valves or inner cardiac layers, and can be caused by bacteria or fungi. Common causative organisms are bacteria like streptococcal, enterococcal, and staphylococcal. Risk factors include structural heart disease, rheumatic heart disease, which we will discuss in the same class after some time, and then the prosthetic valves or congenital heart disease, any infection or chronic IV access. This can be the risk factors. And major cause or pathophysiology, how this bacteria entering the endocardium can be through the oral cavity. Oral cavity, that means any invasive procedure, any dental invasive procedure for the patient. Otherwise, it may be any infection, especially genitourinary infections, or then the surgical procedures like IV cannulation or cardiac artificial placement or pacemaker placement, or any surgical procedures can also be a causative factor, or can also lead to the pathophysiology of endocarditis. Okay. So, what are the symptoms of endocarditis? Very, very, very important point, and it has been asked in many questions of, NCLEX and also multiple choice question. So, what are the symptoms of endocarditis? Remember, the symptoms of endocarditis is from Jane. First one is increased temperature or fever. It's here. Fever. Roth spot, don't worry about the Roth spot, Osler's node, and Janeway lesion. I will have a separate detailed discussion about them in the same class itself after this slide. Okay, so first one is fever or increased temperature. Then the patient will have a Roth spot. Then Osler's node, cardiac murmurs. We all know what murmur is, a blushing sound between the heartbeats. So murmurs. Janeway lesion, arthralgia and anemia. Arthralgia means the pain of the joints, arthralgia and anemia. Nail bed hemorrhage, remember this name, nail bed hemorrhage. Okay, nail bed hemorrhage and emboli. These are the signs and symptoms of infective endocarditis. So, from Jane, fever, Roth spot, Osler's node, murmur, Janeway lesion, arthralgia, anemia, nail bed hemorrhage and emboli. So this has been asked in a previous question paper, that in which disease condition Osler's node and Janeway lesion are seen. This was in which cardiac condition Osler's node and Janeway lesion are seen. This was a previous NCLEX question. So remember, in infective endocarditis, the patient will have a signs and symptom of Osler's node and Janeway lesion. Okay, so other than Osler's node and Janeway lesion, the patient will have cardiac murmur and arthralgia, anemia, nail bed hemorrhage and emboli. So, what is Osler's node? One more here. Petechia is also there. So remember, from Jane P. From Jane P. Okay, from Jane P. P is for petechia. So what is this? What is the Osler's node or Roth spot or nail bed or all these things? So what is, first we'll go nail bed hemorrhage. What is the nail bed hemorrhage? The nail bed hemorrhage is also known as splinter hemorrhages. You can see it here, splinter hemorrhages. So either the question can be asked as nail, that's why I'm adding both the names in the slides. Okay, either the question can be asked as a nail bed hemorrhage, or it is also known as splinter hemorrhage. What is nail bed hemorrhage or splinter hemorrhage? It is a small areas of bleeding under the nails. Okay, it's nothing to worry, nothing very difficult to study. It is only a small bleeding under the nails. So the thing is, it has two names, either nail bed hemorrhage or splinter hemorrhage. Both are the same. And then we studied about the Janeway lesion. What is the Janeway lesion? The Janeway lesion is a plain lesion. That means no tenderness, no tender hemorrhage, or no lesion, but it is just like a difference in discoloration of an area that most commonly seen in the fingers, toes or earlobe. So remember, Janeway lesion, Jane plain, remember Jane for plain. That means there is no enlargement or no nodal or anything. It is just a plain lesion, that is Janeway lesion. And what is Osler's node? Osler's node, you can see here, most of the times it is seen on the hands and fingers. This is Osler's node, seen on the hands and fingers, and it is nodes, like small reddish tender nodes. It is nodes, okay? They like an enlargement, it is like this, okay? At the same time, Janeway lesion has no enlargement, it is just like a plain thing, okay? That is Osler's node. And then we studied about splinter hemorrhage and Janeway lesion and Roth spot. Very, 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 very important. Roth spots are seen on the fundoscopic examination. What is fundoscopic examination? Fundoscopic examination is used to visualize the eyes. Fundoscopic. So Roth spot is visualized by fundoscopic examination, and it is coming up like a retinal hemorrhage. Retinal hemorrhage, that means the hemorrhage in the eye, retinal hemorrhage. This is a Roth spot, and there are two other names for Roth spot. Roth spot is also known as Lytton spot. Just in case if the question comes up in a different name, I want everybody to remember. Roth spot is known as Lytton spot, okay, or Lytton sign, and it is visualized by fundoscopic examination, and this is seen in infective endocarditis or endocarditis, okay. So what were the signs and symptoms we studied for endocarditis? The mnemonic is from Jane P. The signs and symptoms are fever, Roth spot, Osler's node, murmur, Janeway lesion, arthralgia, anemia, nail bed hemorrhage, and emboli and petechia. What is petechia? Petechia is like small 1 to 2 millimeter diameter red or purple color spot on skin. Okay, so this is 1 to 2 millimeter red or purple colored spot on skin is called petechia. And how is petechia occurring? Petechia is occurring due to the broken capillary vessels. Capillaries are very small blood vessels. In case if there is any broken capillary vessels, we will have 1 to 2 millimeter sized red or purple spots on the skin. That is called petechia. So remember the signs and symptoms, very, very important. Signs and symptoms of the endocarditis is very important. The questions have been asked before, like which disease condition Osler's node and Janeway lesion are seen, and also asked about what is if in some question papers they are giving the images. They are giving the images, and they will ask what symptom is that, or what is the name of the given rash or lesion in the image. So either they can give the Janeway lesion, that is like a flat one, or Osler's node, mostly seen on the fingers and toes of the patient, and Roth spot. This has been asked in a central government examination. This image was given and asked what is the name of the symptom shown, and the name was Roth spot, either Roth spot or Lytton spot or Lytton sign. This is the Roth spot or Lytton spot. This has been asked. I have seen this picture in a question paper, and it clearly asked what is the name of this symptom given below. It's Roth spot, and it's a retinal hemorrhage, and it is assessed by fundoscopic examination. Fundoscopic examination is the examination used to assess the Roth spot or retinal hemorrhage. Okay, so now we know all the important signs and symptoms of infective endocarditis. And how are we going to diagnose the endocarditis? Very, very important. Remember, for endocarditis, I want all of you, if somebody say you the name endocarditis, I want all of you to remember the name of a bike called Duke. Endocarditis, go to Duke. You all know the bike Duke. There is a bike called Duke. Okay, so endocarditis is assessed or diagnosed by modified Duke criteria. Okay, so what is Duke criteria? I have bought a new bike and its name is Duke. Okay, just imagine. I don't know how to ride a bike. Sure, just imagine I have bought a new bike and the company is Duke. Why did I buy this bike? I want to be timer. I don't want to be late. So remember, endocarditis is for Duke. Duke is for be timer. So modified Duke criteria for infective endocarditis, the mnemonic is be timer. So this modified Duke criteria has two criteria in that. One is major criteria, very, very easy to remember. Okay, don't worry about the things what I'm saying. It is very easy to remember. So just concentrate. One is major criteria. Second one is minor criteria. So in the major criteria comes B. And the minor is timer. Okay, so endocarditis, Duke criteria or modified Duke criteria. Pneumonic is B, timer. In the major criteria, that is B is for blood culture for positive more than 2 times in 12 hours apart. So if you do a blood culture for a patient, the patient's blood culture comes up a positive result for more than 2 times in 12 hours, that is positive for the endocarditis. No, it is positive. And then echocardiography. Okay, so BE, major criteria BE, that is blood culture and echocardiography. Next one is minor criteria for timer. T for temperature, E for immunological phenomena. How will you identify the immunological phenomena? That is Osler's node and Roth spots. They are all immunological evidences. So this is a minor criteria. Osler's node and Roth spot are coming under immunological phenomena, and it is a minor criteria. And then microbiological evidence, that means a positive blood culture. Okay, but the positive blood culture is there, but it is not same like the major criteria. That means in major criteria, the patient should have a positive blood culture more than 2 times in 12 hours. But either if the patient has only one positive result for the blood culture, it will come under minor. Then embolic phenomena presence of emboli for the patient or painless skin lesions. Then the risk factors. What are the risk factors? IV drug users, prolonged use of IV cannula, or any genitourinary history of any genitourinary tract infections, or invasive dental procedures in last 3 to 4 months. They are the risk factors. The presence of any risk factors will also be considered as minor criteria. Okay, so now we got a patient and we are doing the modified Duke criteria assessment for the patient, and we got 2 major criteria. These 2 criteria are positive. That means the blood culture is positive 2 times in 12 hours, and also the echocardiography shows the evidence of endocardial involvement. Then the patient has got a endocarditis. That is how we diagnose the condition. And if the patient has not got all the 2 criteria, all the 2 major criteria, this is definitive diagnosis is here. 2 major criteria, if you got them both positive, then the patient has got endocarditis. Or either one is positive and 3 of them are positive in here, then it is endocarditis. Or else the 5 of them are positive and these 2 are negative, but still these 5 are present, then that is also endocarditis. So if the patient has got both of the 2 major criteria positive, then we can diagnose the patient as endocarditis. Otherwise, the patient has got 1 major criteria and 3 minor criteria positive, then that is also endocarditis. And the patient has not got any positive in the major criteria, but all the 5 criteria in the minor criteria, if they are all positive, then the patient has got a definitive diagnosis of endocarditis. Okay. And this is definitive diagnosis that the patient is going to be diagnosed as endocarditis. And what is possible diagnosis? That there is a query of diagnosis. That means 1 major criteria and 1 minor criteria. If the patient has got only 1 major criteria and 1 minor criteria, 1 major criteria and 1 minor criteria, that is a possible diagnosis. Or 3 minor criteria is also a possible diagnosis. So remember, in the case, this question has most of the times asked for NCLEX or prometric or DHA examination. In a case where the question is asked, like the patient has got, we are assessing a patient with a cardiac abnormality, and the patient has got 2 major criteria in Duke criteria and 1 minor criteria. What is the definitive diagnosis of the patient? That is endocarditis. Okay, and I want all of you to remember, if somebody says modified Duke, that means that is a way to find endocarditis. We are riding on the Duke bike to find or diagnose endocarditis. Remember, Duke, modified Duke criteria is for endocarditis, and it is used by a mnemonic called B timer. So B timer is the mnemonic we used for the diagnosis of endocarditis. So what is the management of this patient? What is the management here? So we are going to manage the patient by rest And anti-embolism, we said if the patient has got an embolism, or monitor for the heart failure, and a monitor for any emboli present. And these are the things we can do to assess the patient or manage the patient. Or we have like surgical infection, surgical intervention. What are the surgical intervention? Like excision of infected material, excision of infected material, because I already said there is a risk factor, or the cause of the infection can be any infected material inside the heart, like infected prosthetic valve or a artificial pacemaker, which can result in the infection. So we have to do a surgical intervention and excise that, like take it off, the infected material, take it off, or reconstruction of cardiac or valve structure, like we can put a prosthetic valve, new prosthetic valve for the patient. And we have to prevent the patient from any complication that can be resulting in fatal conditions for a patient who has got an infective endocarditis. Okay, so this is all about endocarditis, and I have also discussed some of the questions which has been asked from this topic. Now we move to another inflammatory cardiac disease, that is called rheumatic heart disease. Rheumatic heart disease. This rheumatic, whenever somebody says rheumatic heart disease, I want all of you to remember it's a serious condition caused by untreated or recurrent rheumatic fever. Imagine a particular person or a patient has got a rheumatic fever and it is coming up recurrently, but it is left untreated. The patient is not ready to go to the hospital or not ready to do any treatment, and it is resulting in the damage of the heart valve. So this result in the damage of the heart valve of the patient. Okay, so remember, if a patient has got a recurrent rheumatic fever, rheumatic fever, and the patient is not getting any treatment, the patient can go to the complication called rheumatic heart disease, and this rheumatic heart disease is going to affect the heart valves. So when I say valves, I want everybody to know most important valve which is affected in a rheumatic heart disease is mitral valve or bicuspid valve. Okay, somebody says you rheumatic heart disease, I want you to remember the patient's mitral valve is the most is the valve which is under the most risk for a patient. Okay, so now we said what is rheumatic heart disease and what is the cause of the rheumatic heart disease. We already said it is a rheumatic fever. And what is causing the rheumatic fever? So remember, the rheumatic fever caused by repeated throat infection or streptococcal throat. Okay, streptococcal throat or throat infection. When somebody says rheumatic heart disease, I will go with gas. What is gas? Group A beta hemolytic streptococcal. Group A beta hemolytic streptococcal infection is the culprit here, that is affecting a throat infection for the patient, and the patient has left untreated, and this throat infection resulting from the gas or group A beta hemolytic streptococcal is resulting to untreated rheumatic fever, and thereby it is going to affect the mitral valve of the patient, that is rheumatic heart disease. Okay, so remember, group A beta hemolytic streptococci is the culprit here. This has been asked a couple of times. The question was asked like, among the options given below, what is the microorganism resulting in rheumatic heart disease? And the question was like group A beta hemolytic streptococci was a option. Next one is group B streptococci, and group A staphylococci. So the only purpose of that options were to confuse the the person who is doing the exam. That was only purpose. So remember, how are you going to remember that? I want all of you to remember, if somebody says RHD, you're going to remember GAS, group A beta hemolytic streptococcal infection, which is going to cause a patient with a throat infection. That's going to be coming up with a throat infection, left untreated. The patient is going through a rheumatic fever, left untreated. The patient is going to have a rheumatic heart disease, which is going to affect the mitral valve of the patient. Okay, so what are the risk factors? That's a very important question to ask during the examination. What are the risk factors? Major thing is the age. I don't know how many of you have got a placement, or how many of you have worked in a cardiac ward. I have worked in a cardiac ward for nearly 1.5 years, and I have seen numerous cases of cardiac. When I was working in India, I have worked in the cardiac ward, and I have seen numerous cases where the patients are between the age of 5 to 15 years. 5 to 15 years with the rheumatic heart disease. Age of 5 to 15 years, or the children are mostly affected with rheumatic heart disease. And then there is like poverty. Obviously the patient has got an infection, but the patient is not going to the hospital because they have other responsibility to be taken care of. Or malnutrition. Okay, these are the causes. Or overcrowding. These can be the causes of rheumatic, or risk factors. These are the risk factors of rheumatic heart disease. Now we go to the signs and symptoms of rheumatic heart disease. Okay, do you know the reason why I am teaching you endocarditis and rheumatic heart disease in the same time? Like why I am teaching it together? The thing is, I don't want you to confuse between rheumatic heart disease and infective endocarditis, because when I was saying about endocarditis, I said we are using the criteria Duke's criteria for the assessment. And in rheumatic heart disease or rheumatic fever, we are using Jones criteria. Okay, so endocarditis, Duke criteria, B timer was a mnemonic. Now we are going to do the Jones criteria or modified Jones criteria for the assessment of rheumatic heart disease. Remember the Jones criteria. Just like the Duke's criteria, in rheumatic heart disease, the Jones criteria also has major criteria and minor criteria. The mnemonic is cases FRAP. C for carditis. We all know what carditis is. Already the patient has got an infection. So carditis is the inflammation of the heart. Arthritis, inflammation of the joint. Rheumatic. Remember, rheumatic always goes with the bones or arthritis. Okay, arthritis, carditis, subcutaneous nodules. The patient might have a subcutaneous nodules. Erythema marginatum. Sydenham chorea. Don't worry, I will go to it. Never worry about that. Erythema marginatum, Sydenham chorea. And the minor criteria are fever, FRAP, fever, raised ESR or CRP, arthralgia, like joint pain, prolonged PR interval. We all know PQR. The PR interval will be prolonged, and previous rheumatic fever. So always check for the rheumatic fever history for the patient, or check for the throat pain or any throat infection happened in the previous 3 to 4 months for the patient. Okay, so Jones criteria used for the assessment of rheumatic heart disease or rheumatic fever, and among the major criteria cases. First one is carditis, then arthritis. Itis means inflammation. So carditis is inflammation of the cardiac wall or the cardiac muscles. Arthritis is inflammation of the joints. And then we studied about the subcutaneous nodules. The subcutaneous nodules, like on the subcutaneous tissue of the patient will end up with the nodules. And then we studied about erythema marginatum. What is it? Erythema marginatum is the ribbon-like rashes seen in chest, back, and abdomen. So remember, if a patient has got a ribbon-like rashes, erythema is always ribbon-like. Okay, erythema is always like a ribbon. Erythema marginatum. If the patient has got a ribbon-like rashes on the chest, abdomen, or back, the patient has an erythema marginatum. And then what is it? Sydenham chorea. Sydenham chorea is the involuntary movement of facial muscle or extremities. Okay, so remember Sydenham chorea, erythema marginatum. They are the very, very commonly asked question regarding the rheumatic heart disease. Okay, if a question comes up, what is erythema marginatum? You all know it's seen in the rheumatic heart disease. It is like a ribbon-like rash seen on the chest and abdomen of the patient. And Sydenham chorea is the involuntary movement of the facial muscles and also the extremities. See it's going to here. See the patient's moving, hands are moving. The image is showing up like the patient's hands are moving. That means there is an involuntary movement for the patient. And erythema marginatum is a, always remember, ribbon-like ribbon like rashes seen in the chest and abdomen of the patient. And then is another thing is migratory polyarthritis, that is the painful joint pain or seen in the also seen in the patient who has got a rheumatic heart disease. So there must be evidence of streptococcal infection. The patient should have a gas. What is group A beta hemolytic streptococcal infection? Group A beta hemolytic streptococcal infection. And along with that, if the patient has got either of the two major criteria or one minor criteria, or two major criteria. If that patient has got two major plus one minor, or one major plus two minor criteria, then the patient has got a diagnosis of rheumatic heart disease. Okay, it's very important to know the signs and symptoms seen in infective endocarditis and also seen in the rheumatic heart disease. That is the reason why I have discussed both the conditions in the same video, so that you will not get it confused. Okay, so what is the management of rheumatic heart disease? Management of rheumatic heart disease can be rust or diuretics or digoxin medication can also be administered for a patient with a rheumatic heart disease, and antibiotics. Why antibiotics? Because it's an inflammatory disorder. Most commonly given is penicillin 250 mg BD can be, most of the times the prescribed medication will be penicillin or amoxicillin. Amoxicillin can also be administered for a patient who has got rheumatic heart disease, because it is caused by group A beta hemolytic streptococcal infection. So penicillin and amoxicillin can be given. Otherwise, we can go with the surgical management, I already said, because rheumatic heart disease is always affecting the mitral valve or the valves of the heart, mitral valve. So surgical management can be balloon valvotomy or closed valvotomy or valve replacement. Okay, so these are the surgical management provided for a patient with rheumatic heart disease. So rheumatic fever is, remember few points in that. Rheumatic fever is the most common cause of mitral stenosis, because we already discussed mitral valve is going to affect in rheumatic heart disease. So mitral stenosis is most commonly caused by rheumatic fever. Okay, and how is the patient getting rheumatic fever? Rheumatic fever is occurring because of the prolonged existence of group A hemolytic streptococcal in our body. That probably because of the throat infection. The patient might be having a prolonged time. The patient is suffering from throat infection because of many reasons, like poverty or overcrowding or malnourishment, whatever it is. The patient is not going to get a proper treatment, resulting in rheumatic fever. Patient is still not going to get a treatment, thinking that it is just a fever. What happens is, without proper diagnosis and management of the fever, the patient is going to get rheumatic heart disease. That is an inflammatory cardiac condition. Most of the time, the valve affected in rheumatic heart disease is mitral valve and result in mitral stenosis. Okay, and how can we diagnose the patient? We can diagnose it by Jones criteria. Remember, Jones criteria is used for rheumatic heart disease, and in Jones criteria we have the mnemonic cases FRAP. Cases is the major criteria, FRAP is the minor criteria. Most important thing to remember is erythema margitum, Sydenham chorea, arthralgia, polyarthritis. These are the main of the symptoms seen in the rheumatic heart disease. So what is Sydenham chorea? Sydenham chorea is involuntary muscles of the hands or the face. Involuntary movement of the hands or extremities and the facial muscles. So these are the most important thing to remember. And rheumatic heart disease can be managed by antibiotic, amoxicillin or penicillin. Surgical management is balloon valvotomy, closed valvotomy, or the valve replacement of the patient. Okay, so the valve which is most commonly affected by rheumatic heart disease, mitral valve. So this is for the today's class. I hope you got an idea about two disease conditions, infective endocarditis and also rheumatic heart disease, and the difference between Duke's criteria, the mnemonic is B-timer. Jones criteria, the mnemonic is cases FRAP. Duke's criteria is used for endocarditis. Among the Duke's criteria, most important thing is to identify the symptoms by seeing the image or understanding what are the particular symptoms are. So that is Jane lesions, Osler's node, splinter hemorrhage or nail bed hemorrhage, and Roth spot. Remember, this Roth spot has been asked in a central government nursing examination, and in this question the image was given and asked what is this What is the symptom called? What is this called? The question answer can be coming either as Roth spot or Litten spot or Litten sign. Okay, so remember Roth spot is very, very important. And then we studied about rheumatic heart disease. Rheumatic heart disease, most of the cases it is affecting the mitral valve or bicuspid valve of the patient, ending up in mitral stenosis. Okay, so this is rheumatic heart disease. Whenever somebody says you rheumatic heart disease, remember gas. Group A beta hemolytic streptococcal infection, which is remaining in the patient for a prolonged period, left untreated, the patient can result in rheumatic heart disease. Okay, thank you very much for watching this video. If you have got any questions, you can pop it in the comments and see you in another session. Bye bye.